Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Welcome to Inside Scoop. I'm Bettina Lawton, and I'm your host. And tonight, we're going to sort of follow up on some New Year's Eve resolutions that you probably made. We've given you 30 days, and we are willing to bet that you haven't done a thing. So we're going to give you some encouragement and tell you what you need to be doing to help your mom, your dad, maybe your older siblings. And to do that tonight, I've got two absolutely fabulous guests who know all about this. The first one is Dr. Steve Simmons. He has been with us before. He is with Doc Talker Family Medicine in Vienna, Virginia, but he is also a medical director for a number of assisted living facilities around here. He is board certified in internal medicine. He's a member of the House Call Physicians Association and the Geriatric Society. And he spends a good deal of time on the road. He's really a road doctor because he's always in his car, and he's got all these, little machines and things that he can do in his car. So we're going to talk with him about what he does. And then we have Jody Lyons, and some of you have probably seen her on her own show. She is an author. She has an absolutely fabulous book called The Smart Person's Guide to Elder Care. We're going to be talking about that today. And she has been an elder care consultant for over 20 years. She's a leader in international organizations representing health and long-term care service providers. She is on the board of the Alzheimer's Society in the capital area. She's a graduate of Brandeis University. She knows her stuff, and she's going to tell us all we need to know. So, first I want to know what got you actually all involved and so passionate about taking care of older people, because you clearly are not older people yourselves.
Not yet.
Not yet. We're all headed there, right?
I'm working hard
Thank
for
you.
that. Yeah.
We're going down that road.
Yeah, I like to tell my children that I worked hard to be a middle-aged man, so quit trying to spoil it for me.
Ah, very good. I bet they love that.
Absolutely. You want me to go first?
Yeah, go ahead.
Going back to medical school, I graduated in '93, and started, I guess I feel like I was one of the last of a dying breed. I had an office next to a hospital, and I would see my patients and take care of them in the office or in the hospital, either way. And I lasted about 2 or 3 years at that. And that was in the 90s when there was a split between hospitalist medicine and outpatient medicine, which is its own story. And I feel like I was cast a little bit adrift for a while trying to find what I wanted to do. I didn't want to have that separation. And eventually I found myself doing house calls, and what started as one a week grew into many a day.
Well, now, but I find that kind of odd, because house calls is kind of like 1950s, the guy, on the television set with the perfect little family and running around doing things. I mean, house calls, really? This is 2017. What's that about?
Well, it seemed awful quaint, I guess, and it satisfied my romantic tendencies, to do such a thing when I first started. But then it grew into an awareness of a need. And I found that it was the best way for me to understand complicated stories and to understand how people frequently get admitted and find themselves in and out of the hospital.
Really, by seeing them in their regular environment?
Absolutely. You get to see specifics that could really help. I'd seen a patient once with a stroke where half of her body was paralyzed, and I couldn't control her diabetes. No matter what orders we sent, they wouldn't control. So I remember visiting her, and the way her room was set up is her paralyzed side was the one that was open to her environment and supposed to allow her to reach her insulin. So I was able to solve that diabetic problem by moving her out of the bed and moving the bed to the other side of the room. And
seems like somebody should have figured that out.
Right, but you're not going to figure that out unless you walk into a person's house and you see things like that. And also it can grow into an understanding of people in their environment, and it just opens up the chance for more accurate diagnosing and make sure that people are doing better.
Well, it certainly gets you into the whole family dynamic thing as well when you see people in their homes. It's an interesting.
It does, and it's grown into almost a different sort of a specialty for me. I'm an internist, and I'm supposed to pay attention to detail and really pay attention to a lot of things, and something that I find very important when you go into people's homes. It gives you a chance to see everything.
So you're pretty much on the road all the time? Every time I talk to you, you're on the road.
I try to be on the road. I've morphed into someone who doesn't really like sitting in an office through this experience. That's for sure.
That's good.
Yeah.
That's good for you then.
It is.
Well, Jody, what about you now? How did you end? You didn't start out in this area, right?
No, I didn't. I ran medical societies for a long time, and then I ran a nursing home association and did a lot of the regulatory work to improve quality of care in nursing homes. And I came back to my office one day after a meeting, and somebody had asked for help for her grandmother. And that's when I realized exactly how siloed the industry was, that the nursing home people talk to the nursing home, assisted living talks to assisted living, that if you have a problem in Northern Virginia and your best place is in Montgomery County, for example, in Maryland, nobody will tell you that. And so I decided it was up to me to try. And so that's why I've been doing consulting throughout the country.
Now, why is it so siloed? I mean, particularly in an area like this where, Maryland is right there. It's not like we're in the middle of New York and you got to go 5 hours to get someplace. How come how come that exists? I don't understand why that's that way.
I think a lot of it is payment system driven.
Oh,
That
okay.
it's, if you're on Medicaid, you stay in your individual state. If you're using Medicare, it's only going to cover certain things. And if it's private pay, a lot of people don't look past their local neighborhood. And honestly, in our area with the traffic, which you spend most of your time in, we can understand why somebody might want to only be a mile from the house.
Yeah, absolutely. Well, let's talk about, because we were talking about this actually during the holidays when we ran into each other, about the holidays being a time when people, they go back home, they see mom and dad, they see folks they don't normally see, and they go in and it's like, what has happened here? So let's talk about some of the things that people see when they haven't been home for a while and all of a sudden it's there. And the folks who are in the area probably don't notice it. It's one of those incremental things where all of a sudden you look and there's nothing in the refrigerator or the laundry's not getting done. What are the kind of things when you are back with the folks or with older people that you know that are sort of warning signs that if you see it, you really ought to look and say, this is not a good situation. What's going on here?
Well, that's a great question. And I always say to people, the first thing is don't panic. As you get older, sometimes it's harder to shift between tasks.
Right.
And so sometimes mom will put the turkey in the oven and forget to turn the oven on. Because the phone's ringing, somebody's asking her for directions, somebody needs the Wi-Fi password, the kids are underfoot and the dog has to go out.
Right.
That's very, very different than a change in behavior or not being able to recover. So making a mistake and catching it is one thing. But I also say to people, and I call you all the time after the holidays and I say, Dr. Simmons, I need you for the next 6 people. When it makes the family nervous, it's worth looking at, but it's also important to make sure they're not overreacting.
And how do you, you're not there that long. Well, my sons, when they came in, they were in for a couple days. Can't people fake it for that long? I always assume people can fake it for that long.
I think it depends on a lot of things. If a person's still married and for instance, your mother and your father are both still living, one could easily be covering for the other. You find a lot of times with the death of one of your parents that very quickly you can find out that the other one was being supported in large fashion by the person who had just passed. So I would say first that assisted living directors, I know, consider this their busy season.
Yes.
The holidays. That's when people come and they look around. It's the nature, I think, of how we all live our lives, or a lot of us, is we're very busy during the year, and then we take time to come home for Thanksgiving, and maybe mom forgets to take the turkey out or doesn't make the dressing right, like she has forever. It could be subtle
sons tell me
things,
that all
right?
the time, but I don't think it's...
Well, then there's a preponderance of things. If you see a lot of things add up that are small, or if you see really big things, maybe the mail that has always been handled is now stacked up on the desk. Maybe there's a lot of, I hear a lot about bills that haven't been paid.
Yes.
And weird events around the house. So look for the routine, look for what you're used to seeing, and if something's off, most people know and they start asking questions.
And one of the biggest clues is the scammers. You know that this time of year the scammers are terrific, and you've won the lottery and all you have to do is mail me a check for like $5,000 and then I'll send you $5 million.
Wow.
you'll start to notice different pieces of mail or different kinds of phone calls coming in, and you can tell that the person may be on the sucker list by the number of times. I mean, you do this all the time. You're the one who recognizes it, that they've actually written the check to the scammer.
Right.
Yes, indeed.
More than once.
Yes.
There's other medical things that I would listen to is if you're thinking mentally, perhaps a person who's never repeated a story is now repeating the story over and over again as if it's new. Perhaps they're forgetting certain things or events, or they're showing an inability to remember what happened 10 minutes ago. You know, the short-term memory starts to go. And then another one would be physical change and physical decline. Are they able to get their buttons on? Maybe it's askew when they get dressed. Perhaps the makeup's not really at all correct, you know, for somebody who could. So you see a lot of difference in routine. So you have to know someone to see a problem that's early. Other than that, it's so overt, you don't need our advice. You're going to know.
You're going to know. Now, what should you do? So if you're home and you see this, because I remember, and my parents, my mother died very young, so I didn't go through any of this with her, and my father didn't last all that long either. But I remember when he got to be about 74, he started being angry. And I realized part of the reason he was angry was exactly that. He was forgetting things. He got, you know, somebody told me he got lost coming home one time. I mean, he'd lived there for 50 years. But it's very hard to say to your father, hey, Dad, I
don't think anyone knows how to say that. How to bring that up. And people bring patients or their loved ones to me and hope that I'll say it or that I'll figure things out. And I think that is where you start, though, is you try to, if something's off, if something's different, you really, the best case is that they have a doctor that you can take them to that knows them. That's your best.
Well, I always
best case scenario.
As you know, I say to my attorney friend over here, if you think you have a problem, you go to the lawyer and the financial advisor first, because yes, you have a problem, and you get all your paperwork in order first, and then go get a diagnosis.
Yeah, because you have trouble once I've given a diagnosis.
Exactly.
Right, that's exactly right. Well, we are going to be taking a break, and then we're going to talk some more, because I really want to get into what do you do.
Absolutely.
Because the people that I deal with are generally feeling fairly helpless and not really being sure what they need to do. And the documents, as Jody just said, are really key to get them done, and get them done early. Don't wait too long.
Amen.
So stay with us, because we are going to be right back and continue this conversation.
There's more than just books at the library.
There's more than just books at the library.
Excuse me.
There's more than just books at the library.
Il y a plus que de livres à la bibliothèque.
Hello. You have a lot of great books here today. You know there's more than just books at the library.
I know.
There's more than just books at the library.
I don't want to be hooked to a machine.
I want all the medical treatment available to me.
I wouldn't want my family to have to make this decision.
My doctor knows what's best for me.
An advance directive is your life on your terms. Talk with your family. Decide what's right for you. Then put it in writing.
Documenting my wishes today means my family won't have to make heart-wrenching decisions later.
To learn more, visit www.putitinwriting.org.
1,200 American youth run away from their homes every day. The National Runaway Switchboard is here to help. 1-800-RUNAWAY. If you are a runaway, thinking about running away from home, or a parent or guardian concerned about issues facing your child, call us 24 hours a day. 1-800-RUNAWAY. In times of crisis, hope is just a phone call away. 1-800.
We're back to the Inside Scoop. Here again, your host.
Welcome back. This is Inside Scoop. I'm Bettina Lawton, and I'm your host, and I have with me tonight Jody Lyons and Steve Simmons, and we are talking about helping out our friends and elderly folks, our parents maybe, who we go home at the holidays and something is wrong. And when we went to the break, Jody was talking about documents that needed to be done. And, you know, most people don't think, oh, let me get the documents first.
Right.
They think, let me go find out what's wrong first.
Absolutely.
Right.
But the problem is, and of course, so the way this works, for those of you who all don't know this, is I'm the attorney, he's the doctor, she's the elder care consultant.
Right.
So you really can't, if I get handed something from you saying this person has dementia, and not just mild dementia, but serious dementia, you're done. Game over. You can't sign the papers if you're not competent.
Right.
But what I always have to explain to folks when they come in and they're worried is you don't have to be a rocket scientist to sign the documents. You know,
Correct.
if you have mild dementia, I can probably do a power of attorney for you. I can probably do your medical directive and maybe even a will. Am I going to be putting you into a trust? Am I going to do anything complicated? Maybe not. You may not be able to do that. But do you know who you trust? You know, do you know what you want? Can you tell me what do you want to have happen? And if you can do those kinds of things, we can work with that. If it's really bad and truly they can't function, they don't know the time of day, they don't know, you know, the usual tests that you do, then we're done. And then it's a whole other, you got to go to court, it gets messy. So you're very much go get it first and then go see you.
Well, exactly. And that's why the first thing I say is, okay, show me your papers. Do you have, and I don't mean it in any nasty way, I mean, do you have a valid power of attorney that's been written at some point recently enough that it's still valid? And for example, are the people you've named as your powers of attorney still alive?
Right.
Because we've had that situation where, yes, I have the power of attorney document, but there's no living person to be that power of attorney.
Right.
But the other thing, I think the biggest challenge I face is everybody thinks the will is the most important thing.
Oh, it's not.
And as I've said, I even said this to my own parents, I said, at that point, you're already dead. That's just paperwork.
Right.
We need to know a lot between now and then.
Right.
What do you want? How do you want to live? And how do we make sure your wishes are upheld?
Well, and that's exactly right. And people are always shocked when I give presentations and I say to them, if you don't have a will, what do you care? You're dead.
That's
okay?
right. Yeah.
But if you don't have a medical directive or you don't have a financial power of attorney, you're alive. And somebody that you don't know perhaps or you don't trust ends up getting appointed by the court and you're stuck. And so you need to get it taken care of so that what you want to have happen happens. And you know, people, and what you've said about folks who have died or maybe they're no longer competent, because the law changed in Virginia a couple of years back and powers of attorneys, financial powers of attorneys, are perpetually valid. And so they never run out. But people seem to forget that that may be true, but B, people don't like them because they're not registered anywhere. When I say people, I mean financial institutions.
Right.
When you're trying to sell a house with a 15-year-old power of attorney, people don't like that. So you got to keep them up to date, and you got to make sure that the person you named is still in the area. We're very mobile.
Right.
Are they still alive? Are they still competent? Do you still trust them? People change over time. So you really need to do that.
Oh, absolutely. And I think the hardest part, which is why I'm always grateful when you're around for these things, is when you're talking about the the advanced directives, healthcare proxies, MOLST forms, anything having to do with a person's wishes. So I'm always grateful to rely on you for those.
Yeah, those are the hard ones. I met with some folks a few weeks back, and the wife in the couple just trying to talk about the advanced medical directive. She was just in tears, and it was the thought of her not being competent was just too much for her. And she was perfectly competent, but it was just she couldn't deal with that prospect. It was really quite wrenching. But you know, what do you do with that? Because I write it at the one end, and I say to folks, I can't write in there, oh, if I get this disease, let me go, because tomorrow we could have a cure for the disease, so you don't want that.
True.
But, so I write this thing, and I say, okay, if I'm in a persistent vegetative state, or I have a terminal illness, or I have no clue what's going on around me, don't take any extraordinary measures. And then you get it.
Right.
What are you doing with that?
And of course, it all depends on the different circumstance and where you're at, right? I've seen scenarios play out in the hospital where everybody's meeting around a conference room. You have it, the family's there, the doctors are there, and everybody's talking. And that's in a more chronic situation where perhaps you've hit a clause that says, I only want to have dialysis for a short period of time, not to prolong my life, or a feeding tube. And again, you get to some language with a feeding tube that would say, if there's no hope for meaningful recovery, and then that's where I have to come in, or the medical community comes in, right? Well, what does hope mean, and what's really, what do we know? A lot of things really don't play out except over the course of time. And sometimes that can be in days or weeks and even longer before we really understand how to give a person hope or take away hope, I guess, for a meaningful recovery for certain hard choices. And I think feeding tubes, prolonged feeding, that would be the best example. I can't remember the exact statistics, but I remember reading that it was millions. It's either and I think it's north of 2 to 3 million people are getting tube feeds in the country.
Right.
And it's pretty interesting, which you would then ask the next question, how many would be receiving tube feedings and maintaining in a persistent vegetative state? And I know that's in the tens of thousands. So those are the things that nobody wants, and everybody's trying to prevent scenarios like that.
But they don't sound like they're getting prevented. I mean, are people like...
Not 100%, no.
And persistent vegetative states are different from comas, if I'm remembering this. You could actually recover from a coma, but if you're actually in a persistent vegetative state, you're not recovering. Is that?
I would have to defer to a neurologist on splitting that hair. And I mean, an internist, we love splitting hairs, but on that one, I would defer to my neurology brethren. Okay. I'm not sure how to split the exact hair on the difference of those. But again, I would go to chance for any recovery, chance to return to who you were before. And if there's not a chance of that, then many times that's when you wouldn't want to prolong your life in a state that many would consider inhuman.
And I think that's why I always punt to people like the two of you, that I know that a client says, I don't want to live like my father did. Okay, well, can we be more specific? And then how do we make sure that your lawyer and your doctor know, and that your family member knows?
Right.
So that you've made your own decision, you've kept your control about what your definition is with medical advice and legal advice.
How much do you find people willing to actually talk? I mean, I always say when you tell me you're going to name your child as your healthcare agent, I always say, have you talked to them? You have to talk to them, because you are expecting them to take this very general directive and interpret it for the doctors to say, this is not the standard of life that my father and my mother wanted. But people seem really reluctant to have those conversations with their kids. And I don't know if it's the parent is reluctant or the kid's the one that's reluctant. But do you see people actually having these conversations in advance?
Well, I find it really funny, because many of my friends have had their parents do something I thought was brilliant. They get colored sticky notes. And the family gets together and they walk through the house and they put colored sticky notes on the stuff they want. So if you want the chair and you have blue sticky notes, you put this thing on the chair, and then that's how they can come up with the will for the stuff. Yet while they're doing that, there is no conversation about, okay, when do I want this to stop? When do I want medical intervention? When do I not? So the conversation about passing away isn't the issue. But for some reason, again, between those 2 points.
I believe most people don't want to have that conversation, because to broach the subject changes whatever mood or whatever moment people are living and experiencing. And if you're just going to see your parents or your family for short time periods, maybe a couple of days at Thanksgiving, Christmas, and maybe a few days over summer, then people don't tend to want to spoil that time. with such an unpleasant topic.
Yeah, exactly.
But you're setting yourself up, and you're setting your parent up.
Absolutely.
Yes.
By not having those conversations, because we're all going there, people.
Sure.
If somebody has figured out a way to not die, come see me, please, because we could make a lot of money together.
There's people that will freeze you.
But I'm don't think that means I'm alive.
No,
I think I'm just
wait
suspended.
closer to the end, I would suggest. I really would. I wish to me, it's just a hard subject for people to start to talk about. But I always think of the Benjamin Franklin quote that by failing to prepare, you are preparing to fail.
That's right.
I think of that often.
That's exactly right. Well, and I think, I read something, and I don't know if it's been successful or not. There was something called Death with Dinner. Did you ever read about these things?
No,
oh my heavens, it was so funny. Remember, they would have those box games, and you invite people over, like Wall Street would be about insider trading and who got murdered and who did what. And they created this thing called Death with Dinner, and they did menus, and they did the music you should play. I mean, they had this whole thing where you set the tone and then invite your family, or if it's your friends who are going to be taking care of you or making decisions. Everybody comes over, and somehow you create the ambiance to talk about this. And
what a great idea.
I actually looked at it, and they sent me some of this stuff, and it was really very fascinating to sort of look at it and say, well, for people who have a problem easing into this conversation, this is kind of a fun way to go about it. But you're absolutely right. People are very, very reluctant.
Yeah, and even if the child is, perhaps the parent will say later.
Yeah.
Well, and you also don't want to say, please pass the turkey, and by the way, I don't ever want a feeding tube. Do you have any gravy with that? It's got to be the right time and attention.
Which is a challenge, right?
Yeah, because what is the right time? I mean, you guys deal with this all the time. You can't do it like the big holidays, but if you make an effort to go home. I mean, I went home recently to visit my brother. I hadn't seen him in a year, and I flew up, and usually I drive. And he thought that I was coming up to tell him I was dying. And when I realized that, I was like, no, I just flew up because it was cheap and easier. And
there was a good flight.
There was a good flight. I took it. It had nothing to do with I had an emergency, and I needed to get up here to see you. But it was really kind of striking because he was dancing around and trying to get me to talk to him about it. And it was very cute. It was very sweet, but it was a little odd.
No, I understand. I scared the living daylights out of my parents when I did my own paperwork, because I said, how many times can I do these presentations, not do my own paperwork, and not be a hypocrite? They thought I was lying.
Well, on that note, we'll be back in a few minutes.
Some dreams are universal. Dreams that inspire us. Multiple sclerosis is a devastating disease that changes lives forever. The National MS Society does more for people with MS than any organization in the world. But we can't do it alone. To get involved, visit us online at nationalmssociety.org.
What's wrong with this picture? Half of young Americans can't locate economic powers like Japan and India. 20% can't even find the Pacific Ocean. Without geography, our children aren't ready for the world. Geography is everywhere. It's incredible creatures, rhythm, fashion, flavor. It's economics and politics. It's change. Understanding connections between people and places is critical in the 21st century. That's why we created mywonderfulworld.org. Go there now for your free parent and teacher action kits and give our kids the power of global knowledge. Because kids who understand our world today can succeed in it tomorrow.
We're back to the Inside Scoop. Here again, your host.
I'm Bettina Lawton, I'm your host, and we are here with Dr. Steve Simmons and Jody Lyons, and we're going to start talking about brain health, because I want to find out, you see all of these ads that pop up that tell me if I would just take this substance, or if I would just work out with weights, or if I would just do something, that I will be protected from dementia and my brain is somehow going to be fabulous, which it already is, we know.
Right,
but
absolutely.
It will stay fabulous.
We just want to keep it fabulous.
Yes, exactly right. So is any of that true? Should I be buying all this stuff?
You should be moving your body, eating well, and engage socially, but I don't know that you need to buy certain vitamins, supplements, and brain health pills.
Okay, because I keep seeing it in brain health diets, and
there's a lot to that. What you eat matters quite a lot.
Oh, it does.
Most of your dementia communities will try to market a Mediterranean diet as the most brain friendly, and there's quite a lot to that actually.
Oh, so pasta is good.
I think you can have to get the right pasta, actually.
Yeah, 10 pounds of it at one time, probably not so much.
No, we'd have to have you talk to a nutritionist about those habits, I think. But,
okay.
No, I mean, you want to exercise. That's a really big thing. When you don't want to get dementia, if you want to protect your brain health, you're not going to be able to do that if you become a couch potato. And just get takeout all the time. You're not going to protect yourself. You have to move your body, you have to be in motion, you have to exercise somewhat. And it's no good to be a social recluse either. You need to go out in the world where people irritate you and try to deal with that in a social manner. You've got to engage yourself with people and exercise and eat well. And those would matter more than any pill that you could take that's marketed towards brain health, I would say.
Well, except for hanging around people who annoy me, I'm with you.
There you go. But the other thing is you have to look at, when they talk about the diets, he just referred to a real lifestyle management food intake.
Right.
There's no miracle diet. You can't just go swallow the supplements. One of my personal pet peeves, and I know you hear me say this all the time, so I apologize, you hear it again. I hate when people say coconut oil cures Alzheimer's, and neither does kale.
Kale?
Kale.
Ooh.
I don't want to talk about kale, but I mean,
That's
for
good, 'cause we
me,
don't either.
I think there's something in, if you'll hear the way people will say the word Alzheimer's, you'll catch that a significant percentage of people will say the word old timers. You'll catch that in what you're actually hearing people say. And I think that smacks of inevitability, that it's inevitable that we will all develop Alzheimer's. And I think you can almost, if you go to the Alzheimer's Association website, they'll point out that stage 1 is everybody at this table right now. Normal is stage 1. So I, personally, for me, I don't like the concept that it is inevitable. I think we all have about a 10% lifetime risk. If there's a first-degree relative, the risk is about double. You can find different studies that say different specific numbers, but having a family history does increase the risk.
Well, that's certainly a heck of a lot less than what you hear me, because people do make it sound as if we're all going to end up with dementia as opposed to a 10% risk.
Right.
And then there's the idea that if we all live forever, if we can all start making it to 130, then maybe they'll be right. But it increases with each decade. There's certain genetic problems that make the age of onset earlier, even as early as 55 for certain genetic mutations that we know about. But I just do not like the concept that there's nothing you can do. I think that you've got to get out there, you've got to be a part of the world, you've got to be a part of a social structure surrounding you, and then you've got to take care of your body, and you've got to eat right if you really want to reduce that risk.
Okay.
And I think the Nun Study. It's like the book The Nun Study would probably be the easiest book for me to refer anyone in the audience to, which is a fascinating book about brain health and the difference. You can read what
in nuns.
In nuns, absolutely. There's several nuns. I forget now which state they're in. And they all have pretty much the same diet, the same living circumstance. The difference is what happens when they leave and go out into the world. And there's quite a few examples of those that were walking and exerting themselves physically had less incidence of dementia. There was In the book, you can learn that they all are autopsied at the end. All the nuns' brains are looked at, whether they were fine or not. And every year, they have very detailed neuropsychology evaluations. So you can look and see whether or not they clinically were behaving in a dementia way, and then you combine that with knowledge of what their brain looked like. And there were nuns who had Alzheimer's-looking brains that had no clinical evidence of Alzheimer's, and they were physically active. And there were nuns who had normal-looking brains, but who had dementia clinically as they were alive, and they were sedentary.
So, but when you say physically active, what does that mean? I mean, I know I think it's the Heart Association who says you ought to walk like 10,000 steps a day. I mean, is there some standard for dementia that says, here's what you need to do if you want to try and hold that off? You're
going to run into a lot of different organizations that have specific advice, whether it's to have 30 minutes of aerobic activity 3 times a week to anything more than that. You're going to get different advice from different people. I tend to find out where my patients are and say, how about a little more now?
Okay.
And then I'll try to encourage a little bit. More and more and more. I want to see more activity, more aerobic activity for sure.
Okay.
But apparently, when he says go to the gym, he doesn't mean pull your car into the parking lot and talk to him on the phone. You actually have to get out of the car,
you got to move your body,
go to the equipment and everything.
You have to get past the juice box.
Yeah. Apparently.
Good Lord.
Apparently, it's just a technicality.
That's right. There's nothing about having the money come out of your account that's going to improve your brain health whatsoever.
Oh, I see. Because there are all those people, of course, we know on our New Year's resolution theme that have said they were going to start going to the gym, and you see them for about a week or two.
Yeah, that's the number one.
Yeah,
right.
And then all of a sudden the machines are open. There's no problem
anymore. I have a friend
right?
who says you can go in March, you can never get on a piece of equipment. Go in January, you can never get in on a piece of equipment. By March, it's all yours.
It's all yours. Oh, absolutely right. That's absolutely right. So now, I have heard the phrase reversible dementia, but I've always heard that it's not reversible. What is reversible dementia?
You raise the question of accurate diagnostics in a way, don't you?
Okay.
But for reversible dementia, it would be the way I'm always thinking when I meet a new patient, is it reversible?
Okay.
Because I don't want to have on my conscience that somebody came to me and there was a chance to help them gain their mind back, and I label them as unable to ever be helped. I mean, that's a fear of mine. So reversible dementias are medical conditions that mimic dementia, and depression is one of the biggest ones.
So it's not real dementia, but people...
Right. Because dementia, really, in my mind, to be accurate and to really you're using the word correctly, it means there's a permanence to it. There's something that you can't do to reverse or to improve. You could slow the decline. You could, even in the case of certain dementias, such as vascular dementia, which is strokes, if you can just avoid having other strokes, you can plateau and be the same for years. Years. All right. Whereas if it's Alzheimer's, you're going to have a steady decline, no matter what. Yet to engage socially, to eat well. I've seen some of my patients who are admitted to assisted living dementia communities at the right stage. They can really adapt and acclimate to that setting. They become active in the social engagement and the activities they have, and they can seemingly plateau for a long time as well. It's a very interesting thing to see.
And there's a lot of things that are really delirium that look like dementia.
True that.
So what's delirium then?
I've always well, you know, if anybody's ever had a really bad pneumonia or a bad flu and your fever's super high, and you're so confused, you know, when that's happening, and you can even wake up confused as to where you are.
Right. Okay.
It's a very real thing. Now, imagine that a person has dementia and they get that fever, that infection. They're going to have incredible confusion. But delirium would be anything that causes confusion and mimics dementia, I guess, in our discussion. And if you take, let's say, a 75-year-old person who has no dementia and you give him pneumonia, a subtle pneumonia, they can present without cough, which is a true frustration. It happens a lot. So that person with a pneumonia or urinary infection could be acting in a way that mimics a dementia that looks indistinguishable. And yet, it's not. If you can identify that infection, you can eliminate the infection, you'll return them to previous mental functioning, and they'll be fine.
Well, and I think one of the other amazing things when I'm in a home with you, when we look in some of the cabinets and see the assortment of they bought it on TV, they went to the grocery store, they went anywhere and took supplements.
Okay, yeah.
Right. You want to tell if there's any question that your mind is suffering, you really want to be honest and upfront and tell your physician, what you're taking. You don't want to have a bunch of herbal remedies that you're taking and not at least mention it. I think it's a very serious thing when your mind cannot work. I tend to think that our modern medical community doesn't, on a 100% case-by-case basis, take it serious enough. I tend to believe that if you have a problem with your heart or your lungs, you're going to take a picture of it and try to figure out what's going on. And yet I see so many people who lose their mind, go to the doctor, get a diagnosis of dementia, nothing more specific than that, and then there's not a test of the brain at all. There's not even a CAT scan or an MRI. It just confuses me.
Can you see dementia through CAT scans and MRIs? I thought it was not something you could...
No, but you can see things you could reverse. Perhaps, such as a condition known as normal pressure hydrocephalus. Perhaps you see strokes in the brain, and then you say to yourself, we really need to manage the vascular risk factors aggressively to not get another stroke. Or, God forbid, you see a cancer. Or a brain tumor, or a meningioma. I mean, it could be a benign tumor. It could just be a lot of things. I think everybody deserves to have a picture of their brain at some point. If you're going to say they have dementia and say that their mind is leaving them and they're going to be different and not themselves moving forward, I think you need to have a workup done. One of the things I like to say in my mind is no one deserves to be sentenced to brain jail without a jury trial. And you need to have a workup. You need to have somebody think it through, ask if it's reversible, and leave no stone unturned. And then the family and the patient and the clinician treating that patient can know going forward, I have done the best I can. I really tried.
I had no idea that you could end up with symptoms of dementia. I mean, I know about the depression in old people.
I've seen it be just an underactive thyroid that had gone on for 2 or 3 years and the person wasn't taking supplements. I've seen a patient who you just get them on the thyroid medicine, retest them a few months later, and they test much higher.
Oh, wow.
Persistent sleep deprivation.
Or I've seen it for depression too, especially after loss of a spouse.
Absolutely.
Right.
Oh, wow. Well, that's actually really encouraging because for all the folks who sort of look and say, oh my gosh, there's
one of the
nothing,
things you
what are we
could
gonna
do, even you could do, or anyone could do, is the difference in the depressed patient and the patient with dementia is the depressed patient couldn't care less trying to help you make sure they're okay. Whereas the patient with dementia is so eager to prove they're okay, they try harder.
Really?
Right.
That's very interesting. Well, we are going to be back in a couple of minutes to continue this conversation and talk some more about brains and what we need to know, so stay with us.
One day these rats were playing in the woods. Well, it's some matches and that's no good. Listen to smoke before you give it a try. Only you. Don't play with matches. Don't play with fire. Cause there's nothing very funny about nothing very nice. Hole is mine. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire.
Only you can prevent wildfires.
Fire.
Why don't you just wash your car at home?
When I wash my car, everything runs down the street and down into the storm drains. With all the chemicals in the soaps and waxes, the last thing I want to do is poison my own drinking water. At least here, it's all contained and recycled on site. That's why I also take my car in for oil changes instead of doing it myself. I might take a chance on spilling stuff. You know what the best part is?
What?
More time to kick back and watch the game.
How far would you go to protect the planet?
I want you to build an ark.
Here we go. Okay, that's good. Oh, okay. Ow!
Maybe there's another way.
People, the flood is imminent.
Is it too much to ask for a little precipitation?
Go to fightglobalwarming.com to find out what you and your community can do to reduce global warming pollution.
Somewhere around the world, there are men and women of the armed forces risking their lives, helping rebuild communities after natural disasters, collecting toys for needy children, tutoring kids in school. These are your sons and daughters who work to keep us safe, secure, and free. dedicated men and women who put their country first.
Live from the Washington, D.C. area, it's the Inside Scoop, all the news that our viewers want to know. Now, here's the host.
Welcome back. I'm Bettina Lawton, and I am your host. And we are here with Dr. Steve Simmons and Jody Lyons, and we are talking about brain health and dementia and what you can do and what may look like dementia but really isn't dementia. So I want to talk about something that you and I mentioned briefly, and that is the effect of general anesthesia can have on your brain if you're an older person. Tell me about that, because I had never heard this before.
I think I was bringing that up with you earlier when I saw you over the holidays about how I have some of my patients who I think are the smartest ones who will say to me, you know, they're not just weighing out having a hip replacement or a knee replacement with just their hip or their knee, but also with their brain, and that they're concerned that with general anesthesia that they could end up with dementia.
But is that a real fear?
I think it's valid. I've seen quite a few patients who, at end of life, maybe you get a hip replacement in your 90s, early 90s, because you're really doing well physically, but nobody weighs into the risk and benefit of the equation, the risk for dementia. And I actually don't believe there's a number or a percentage risk. It's something I see in practice that I believe you can read about, and I believe it's very real.
Well, that's kind of scary for people not to realize. I mean, you can go in and have a problem with your knee or your hip or have some other things, thinking, oh, I'm going to get that fixed and then I'm going to be great.
Right.
But if you said to somebody, well, there's a risk that your brain could be affected from the general anesthesia, you have to wonder how many people would say,
maybe I'll limp or find another way. But there's other anesthesia. You could talk to your surgeon, you could talk to the anesthesiologist. Can't you do a conscious sedation and perhaps a spinal block? I mean, it sounds so much more invasive and crazy. You're like, what, I'll be awake? Yeah, you'll be really out of it. I don't think I'd call that awake. But you know, there's a lot of other options on that. And also, to me, it's a corollary of when you see people who will, really strange dementias can follow a prolonged intensive care unit stay where you survive over a prolonged intensive care unit stay, a horrible illness. Frequently you'll see somebody come out of that and they won't be themselves ever again after that. So, I mean, that speaks to just making overall good health care decisions and not getting super sick if you can. But I don't really, I mean, if it were me and I was in later life and I was starting to have memory problems, I would stay away from general anesthesia if at all possible. I would, in seeking any necessary surgery, I would ask for informed decisions with anesthesia about the options. And I think you'll find that most surgeons want a really good surgical result. That's what they're measured on. I don't think that any surgeons or anesthesiologists who would have an increased risk of dementia after their procedures, nobody would know. There's no measuring that. There's no way to know that. But they're solely judged or graded based on the numbers and their outcomes for what they're doing. So I think, you know, that you've got to talk to a physician who knows you, that you have a history with, if at all possible, and ask informed decisions about you overall, not just that body part.
Well, I have to wonder when you just said a physician who knows you, because in this day and age, I have so many people I know whose physicians are getting out of the business, or their insurance keeps changing, and so they keep changing physicians, and there's really no continuity in care to have somebody who actually knows you, and it's going to take more than the 6 minutes or whatever it is to see you.
Right. If you're gonna let yourself become a hot potato and go from doctor to doctor as insurance changes, you're going to be cast adrift and no one to guide you. I can remember, you know, what enticed me to become a physician was those relationships, was that, you know, after 10, 20 years with a patient, when a bad day came, that they would have a trusting voice that would talk to them, that had history, that they could listen to. And I do believe we have lost that.
Yeah, I do too.
And it is sad. That's why I always say, if you have a physician who you have history with, then work hard to preserve that relationship. If not, you're going to have to approach modern healthcare as a consumer does, and advocate for yourself and ask the questions, the very difficult questions. Is it worth doing this?
Right.
You know, and not just, you know, the risks of my heart, my lungs, you know, and such, but, you know, or the joint or whatever the surgery is, whether it's a gallbladder or whatever it is, but what's the risk to me overall?
Right.
And I would say if you're thinking about your loved one or a spouse, and there's any memory impairment, you're starting to think, I wonder, or the person's starting on memory enhancers and you're starting to look into it, I would say that's a person that until we know more, you would want to avoid unnecessary stresses, medications, drugs, and general anesthesia if you can avoid it.
Wow. Well, Jody, I wanted to ask you about a comment you had made about something called elder orphans.
Yes.
And what is an elder orphan?
It's a new term for something that has happened all along. When you have adults, we used to think of you'd have a married couple, they'd have 2.3 children and a dog and a white picket fence. And that demographic has changed. So very often you have people who are never married, or they don't have siblings, or they're actually, when they grow older, alone.
Right.
Many of them have actually outlived their spouses, their kids.
Oh, yeah.
And so they're considered orphans. And that's where you come in, because that's what I call Bettina. And I say, hello, Bettina, I have nobody to be a guardian for this person or a power of attorney. There isn't a trusted friend or relative. And that's when they still need somebody to make all those decisions we were talking about earlier.
Right. Well, and I actually have a friend, and I think that we discovered that we know this person, who saw an attorney for the first time, and she is an elder orphan. She doesn't have anybody. And the attorney put herself in as her agent under her health care, and on her power of attorney, and on her executor, and on, you know, the whole thing. She's named everywhere. And when I talked to this friend of mine, she was about to go in for this major surgery out of town. When I heard about this, and I said, well, you've called up this person. I didn't, you know, how long have you known the person? And they said, well, I only met her the one time. And I said, well, does she know you're going in for this major surgery? And this friend of mine said, well, no. And I said, well, how is she supposed to be your health care agent if she doesn't even know you're going in for surgery?
Right.
So is there a standard in the work that you do, either one of you, where you would say, if you are in that kind of a situation where basically a third party, not a good friend, not a family member or relative, is taking on these positions, either as your financial power of attorney or your medical, how often do they need to see you? What should that look like if you're on, if you're one of those elder orphans?
Well, I think that's a great question, because what I say is they have to know you.
Yeah.
And if they're your healthcare proxy, they should know your doctor. I mean, this should not be a surprise when somebody calls up and says, Dr. Simmons, I'm the healthcare power of attorney for whoever, and you say, well, that's the first I've heard of it. You know, there should be a relationship, and it needs to be, I'm not saying they have to have lunch every day, but really there needs to be some regular interaction, and your team members need to know each other. Your lawyer needs to know your doctor. They both need to know your financial advisor, and they need to know some family member if there's a family member around. It can't be a surprise.
Yeah, that I was fairly surprised when I had heard about that, because I thought to myself, well, boy, I would not want to be the lawyer to get the call from another state saying, oh, by the way, somebody's surgery went bad,
and you need to be here now, and you need to sign the paperwork.
Right, exactly.
I hate to make that call.
Yeah, that would just not be a good thing. But let me ask you about something else, because I know we didn't used to have it in Virginia, but now there's actually a website about it. These POLST or whatever.
Post, I think,
Post, yeah.
Right.
Physician's
Every state
order
is different.
of sustaining treatment, I think.
Correct. And like up in Maryland, it's a medical order, life-sustaining treatment.
Right.
Every state has a slightly different acronyms. In fact, in Maryland, you have to have it to do anything. Anything. If I admit a patient to a nursing home, I have to have it. Assisted living the same. And now in Maryland, if I'm just ordering home PT, let's say you had your knee replacement and nothing bad happened, and you're at home and you need to have physical therapy, we have to do one of those now.
But so tell me what's in it. Why is that different from a medical directive?
Because it's more specific. It talks specifically about things. It could talk about what to do in certain specific circumstance. What do you do? Like would you want a blood transfusion if you were to need it? Would you want to go to the hospital if it was necessary to keep you alive. It's
So
just about
I'm getting
everything
physical
you could
therapy
think of.
for my
Right.
knee, and you're going to have to fill out
Right,
some
that's
order
right.
that says.
But
That is
here's,
true.
here's
I
the
am gonna
difference.
have to do that.
As we're sitting
Oh, yeah.
here with the doctor and the lawyer right
Yeah,
here.
I'm gonna have to do that.
So as we're sitting here with the doctor and the lawyer, basically what happens is you do the paperwork for advance directives, right?
Right.
So you're saying the person's wishes, and you're speaking lawyer to hospital administrator, lawyer to nursing home administrator. The person fell down on the ground, the EMTs are listening to him, not you. So when it's a medical order, a doctor has made an order, and it carries the weight of medical order and treatment that way. So it's not a discussion, it's actually orders. Administer this, don't administer that.
That's true.
So these cover, do these also include the DNRs, the do not resuscitates, or you still need a separate document for those?
The one in Maryland does. The one here in Virginia is not legally binding in a way that it is in Maryland. I mean, one of my jokes in Maryland is if I had the H&P in my left hand and the MOLST in the right, they'd take the MOLST if I made them pick. Because that way they can legally bring the patient in and know what to do in an emergency.
Right.
That's something they have to have. So it has power there. Here it doesn't. It's more of a guide that helps us to discuss and understand end-of-life decision making, and it does include a discussion of DNR. Do you want me to resuscitate you if your heart
But
were to stop
you're
beating?
signing it. It's a doctor's order. Don't they have to do
True,
it?
but it's a little bit more than just a DNR. It goes a little bit beyond. It's a DNR and then some.
Okay. So it's going to say, don't intubate me or don't stick me on a ventilator. All of those extraordinary measures we talk about, is that part of what's in this?
Correct. Right. And I think you would be more interested in Virginia because, I mean, we're talking in Virginia.
Right.
But I would point out that the one in Virginia doesn't have any legal binding effect whatsoever on anyone, whereas many other states it is legally binding big time.
Yeah, I had
it's
heard
not
there was
here
an
at all.
issue in Virginia. They were concerned that if they tried to push for that, we'd end up with them saying, oh, no, and start yelling death panels or something.
Right, but I think, everybody needs to talk about end-of-life decision-making, and especially a do not resuscitate order. It's much better to discuss that ahead of time, as well, than to wait until you die, or something happens, because that is a something you need to clarify ahead of time, or you're going to get everything done.
Yeah.
Everything. And everything in a hospital is not good.
No, it's never good. I have a firm belief that I need to stay out of hospitals if at all possible. That nothing ever good seems to come of it when I end up in one. So I won't be there.
It's not a good place to take a vacation.
It's really not any place I want to go. Well, I want to thank you both for taking time. I think it's been pretty illuminating. So those of you out there who made your resolutions and haven't done a darn thing about it, take a look at it. Read Jody's book. Call up Dr. Simmons, Doc Parker in Vienna, Virginia, and get yourself some help and guidance. Thanks for being with us.
Thank you.
Thank you.